don't get intimidated by those big fish on the wall, okay?
I think I was there whenever you caught one of them.
You did? You were. In fact, the little minnow next to him is the one you caught. I put it right out there.
I think that's accurate. Hey, well, I appreciate you doing this. I think this is a cool thing that we haven't tried at Osteogenics yet, but, you know, Instagram Live is set up for Q&A. I see that we've got many people joining in right now. So I think you're somebody that a lot of people already know and don't need a lot of introduction. But, you know, I think one interesting thing for us is that you're one of the kind of original GBR guys. You know, I think that there's like, you know, at least names that I know, there's like a dozen guys from the 90s that kind of mastered these GBR techniques, and you were one of those guys. So I think I think you have an interesting perspective on some of these things. When I got ready to write your caption for when we were advertising this, I looked up and I just put you into PubMed and you had 103 publications, and I thought, holy cow, I didn't know he could write that well.
That's not writing well, that's writing a lot. You know?
That's awesome. And three textbooks, and I know you also do a lot of courses there at your place. So bear with me for a second as I figure out this technology. So start feeding you some of these questions that we're getting from the audience. I know one thing, starting off with the question that I have is, I think in your courses you talk about thin tissue biotype, and I think that you treat thin versus, you know, regular or thick tissue biotype differently. Yep. Can you just talk a little bit about how the biotype plays into your treatment protocols?
Absolutely. I mean, I think that the biotype is, excuse me, so important because it defines the envelope of what you're going to be able to accomplish, but more importantly, defines the envelope of what the dangers are when you're trying to accomplish it. You know, if I'm talking about GBR, for example, I've spent a lot of time making sure that you can keep primary closure, because I believe you can keep it literally over 99% of the time, and I have a couple of pretty good sized papers about that. But thin biotype changes treatment protocols. For example, if you took it in general, I probably do immediate implant placement in the maxillary anterior area about 85% of the time. But when it's a thick biotype, it's probably 98% of the time. Thinner biotypes are a bit less depending on defect morphology, because I'm worried about what's going to happen. What's interesting, and I guess what is one of the hot topics now, is people talk about changing patient biotypes with grafting. Well, you know, when I trained, by the way, you were saying, when you said 90s, you meant 1990, not 1890, right? So just checking that. So, you know, I just want to be sure. So when I trained, we all did a lot of soft tissue grafts, which were obviously from the palate, to thicken tissues around crown and bridge and basically change biotype. So you're doing the same thing now a lot with the GBR. I spend a lot of time putting connective tissue grafts in underneath there at the same time. I'll use more allografts now than from the palate because it's easier for the patient. But I think you have to look at biotype. When I do my diagnosis and my treatment planning, biotype was one of the primary concerns. And a thin biotype will totally change the course of therapy and the way I do things. Definitely.
So are you doing, whenever you have a thin tissue biotype, you said you're like in the anterior maxilla, you're doing maybe only 85% of mediates versus if it's thick, you're doing like 98. So if you have a thin, are you doing soft tissue grafting before you go in and place the implants or do a bone graft? Or are you doing it, you said at least some of the times you're doing it simultaneous. Do you ever do it after you do the bone graft?
Couple of things. I will usually put a connective tissue graft underneath my buccal flap when I'm doing the bone graft and membrane. I say bone graft and membrane because it's very rare not to have a membrane in there, you know. And as you know, I use a lot of titanium reinforced membrane still. What my membrane selection is totally dependent upon defect morphology. Non-space maintaining defect, titanium reinforced membrane, no matter what the biotype is. But in those thin ones, I'll put a soft tissue allograft underneath there at the same time. So
cool. And you said if it needs space maintenance, I know we have with the titanium reinforced, we have like what we call a thick and a thin. So it's 250 micron thick is the original, and then 150 micron thick is our thinner for thin tissue biotypes. Do you think that I know some people think that matters a lot. You know, maybe they're seeing less soft tissue dehiscence with the thinner one, and some people probably think, hey, the 250 works every time for them. What's your take on that? Do do you pick and choose which thickness you use, or do you think it doesn't matter to you?
I think it does matter, but it's interesting. I'm not saying that with a thicker membrane, you can't keep primary closure, because you can. But, why not limit your window of vulnerability, right? It's like in an operating room, you never have sterility, but you try and shrink the window of vulnerability. So if this is another thing that's going to help us, I think it was a great thing when you guys came out with the thinner membrane. They got different ones for different indications. I mean, that was a really perceptive thing to do. And no, I do use the thinner one in thinner biotypes, because why would I not? And as an aside, I laugh about people who say, I don't want to keep that many membranes. You're treating human beings. You have to have an inventory. I think you need thick and thin, and you use them where you have to use them. It drives me nuts. I'm going to do this case. Let's see, what membrane should I order? What are you talking about? It makes no sense to me. So I use them both.
Awesome. With the titanium reinforced, I know that, like, one thing with your case is, like, your results when you remove the titanium reinforced, so whenever you need that titanium reinforced, I know you also use a lot of collagen, but when you need the titanium reinforced for the space maintenance, like, your results, it's almost like the top of it is almost like a perfect rectangle. Like, it's almost like hard 90-degree angles. And I've seen lots of people get great results, and it's more of like a rounded sort of look. Right. And I think it matters for, from your standpoint about, implant emergence profile and how much buccal bone you have. Can you just talk a little bit about the importance and why you take that approach?
Absolutely. Now, this is Pot's opinion, of course. I think that the definition we use for success with guided bone regeneration is actually defective or inferior, because what I'm looking at is not, when I first opened, let me back up. When I first opened, I looked at guys open 10 years. I said, how is this possible? But, I've been doing this now for 41 years, because I started when I was 3, of course, but I've been doing it a long time. And I think that as a result, I want to look at long-term results. And I think one of the primary causes of bone dehiscence and implant failure over time is inadequate bone to withstand the functional forces. So I want a perfectly squared ridge, and I want a minimum of 2 millimeters of bone thickness at the crest. I don't want a sloped ridge, and you put the implant in, and over time you start to lose some bone. So I love titanium membranes to do that, to square that ridge. And now I'm lucky enough, I've got cases now that have been, 30 years with this, and the bone is there. Even when I publish the papers, I bone sound. That's why I don't do many anymore, because it takes a lot of work and I'd rather fish. But, I bone sound every case on the buccal when I put together statistics to know the bone is still there. I think the squared ridge makes a big difference over time. It's thick. It's thick at the crest, Awesome.
One note for our audience. So if you have questions, at least in my view, the bottom right has a question icon with like a speech bubble. And that's where you can send your questions. I know some people may put those in the comments, and our staff may funnel those to the question group. But I know we have our one question in the question feed here is it okay to trim a titanium reinforced membrane where the titanium is? What's your experience with that?
Absolutely. These old rules, way back, I used a lot of Gore titanium membranes way back, and was honestly the biggest Gore user in the country for like 6 years in a row. And they had all these rules, and these rules people still go by them. You don't have to. I cut right through the titanium, makes no difference. First of all, though, if you're not cutting the titanium, I don't trim with a scissors. I trim with a 15 blade, because you can do whatever you want with it and make the shape you want. I only use the scissors when I cut through the titanium. So that's number one. Yeah. Number two is this thing about having to have it go 3 millimeters past the defect or 4 millimeters past the defect. I don't do that, because I secure my membranes with tacks. So I don't care if it's a millimeter and a half past the defect. I tack it in. It's not going to move, and that's fine. By the same token, I don't care if it's a millimeter from the adjacent tooth, because I'm from a vertical releasing incision, rather, because I'm tacking it. It's not going to go anywhere. So I sort of thrown out all those arbitrary rules. They were just arbitrary.
Hey, talking about fixation, I think that's a topic that we get lots of questions about. And
I like to fixate on that, actually. Yeah.
Like how many tacks do you put in normally? What would you say is the average?
You've got to have at least 2, because if you don't, it's not anti-rotational to keep the membrane from going. On average, I probably put 2. Occasionally, I'll put 3 or 4. It's really what I need to hold the membrane where I want it and to keep it shaped. Sometimes you'll even put one on the palate if you're putting something over and you really want to hold it back there. You really can't tack on the lingual. The only way you can tack on the lingual is if you're treating a shark, or my ex-mother-in-law who could open that wide, but I don't do veterinary anyhow, so I can't do that. But so it's mostly the buccal or sometimes the palatal crest.
Okay.
Always at least 2.
Perfect. I'm going to look at the next question. Hey, for the audience, if you guys have any questions related to bone grafting, implants, practice management, fishing, wine, whatever, send us your questions.
You said the important ones you said at the end.
Yeah, that's what we'd really like. That's what I would really like for this to steer to. But we'll answer the dental questions first.
Absolutely.
What type of biomaterial do you use in a vertical augmentation? And what about horizontal? And do you treat them the same, or do you have different protocols for your graft material?
So let me back, if you don't mind, I'm going to back up on that a little bit. So before you talk about what you're putting under that, in my mind, I've got to make sure I keep the membranes covered afterwards. If I don't keep things covered, I've got to compromise in the bone quantity, and I've got to compromise, more importantly, in the soft tissue quantity and quality to help with aesthetics. So I spend a lot of time, I use verticals everywhere. Every time I do augmentation, I've got 4 verticals, 2 buccal and 2 either lingual or palatal. People are afraid to make palatal or lingual verticals because they think they're going to hit something. I've always done it. So with the number of cases I've done, and I've always done it in perio, without exaggeration, I've probably placed, I'm serious, 50,000 lingual verticals over my career. Wow. And I have never killed a patient unintentionally. Okay, so that's fine. So we've got to start with that. I have to be able to take that buccal flap and bring it past the marginal ridges of the adjacent teeth for mobility. Bring the lingual flap up. Maybe use some everted flaps, etc. Once I know I can keep primary closure, now everything changes. So I'm not picking my membrane by, oh no, what if it gets uncovered? I'm picking by defect morphology. So I'm still not to material. I'm on the membrane now. Now comes my titanium membrane if I need it. And it's tacked into place. The resorbable membranes are also tacked into place, always. So now I'll finally get to the material that goes under there. And it depends on what I'm trying to do, right? If I'm going in, for example, I took out an upper incisor and I put the implant in, I've got a pretty wide horizontal defect dimension to the buccal plate. All I'm worried about is when I get that buccal bundle bone resorption, I want to keep my width. So in that case, I'm putting in a xenograft that's going to resorb very slowly or just get infiltrated with bone to help hold that space as I get the bone resorption. If I'm going into a ridge and I'm going to go in and I'm going to be putting implants in later, I'm usually using FDBA mixed with, I've mixed it with a lot of things. Right now, we're mixing it a lot with the amniotic fluid, which works very well, but I'm a very honest guy, and I have to tell you that I was involved in the development of that, so this may sound like self-interest with this company. Sometimes I'll mix it with Emdogain, except the quantity of Emdogain you need for larger cases, it becomes very expensive. So those are 2 I'll use. Do I always put a protein in there, a growth factor? I don't. A simple case with a membrane and a graft underneath it of allograft works fine. Horizontally, I think you should be able to routinely get at least 5 to 7 millimeters horizontally in every case, if you just manage your tissues right. I mean, let's say you've got some obscure, weird, bound-down case, but that's what you should get. Vertically, I use the exact same material, same titanium membranes, same allograft under them, mix it with growth proteins if you think you need a little oomph, tacked into place, and you can easily get yourself minimum of 3 to 4 millimeters vertically every time. But that leads into something else. I use a lot of shorter implants, and I always have. And we can talk about that if you want to. My average implant is 8 millimeters long. So
what's the range of implant length that you'll do? How short will you go?
Well, the 4s are available, and I originally put some in my relatives because I knew they wouldn't sue me if something happened, so because I would have just had them killed. So they worked well splintered together, but unsplintered, I routinely, if I go into an edentulous ridge in a molar area, it's an 8 millimeter long implant routinely. I've put 6s that are not splintered together. I don't have a problem with that. I don't think implant length matters. I think implant diameter matters because let's face it, the forces go to the peri-implant crestal bone. So I do a lot of horizontal augmentation, a lot, so that I've got 2 millimeters of bone on the buccal. Probably do less vertical unless I'm doing for aesthetic reasons because I'm very happy with 6 and 8 millimeter long implants. I don't have a problem with that at all. However, there's a caveat here, and this is a really important caveat, I believe. Excuse me. I spend a lot of time managing parafunction. I would say that the number of patients who bucks in my practice are everybody. Maybe it's because they met me. I don't know. We all have parafunction. The question is whether it's clinically significant parafunction. So do I use neurotoxin for everybody? No, but we use it a lot. We do, I look at their sleep. I give them a home sleep test to take with a masseter lead so I can look at the parafunction, assess it. We use a lot of neurotoxins. We balance the occlusion. I will not go in and just replace tooth number 19 with an implant where everything else is all fallen apart and worn down. So we spend a lot of time looking at the comprehensive care for the patient. So this shorter implant works. You know, there are 2 papers I published. I think it was just, I've lost track of time because of COVID, but there were thousands of cases, thousands of implants with a mean time in function of more than 10 years. And every single one of those cases that failed after a few years in function was a parafunctional patient that I wasn't treating it properly because I wasn't really as fanatical about it as I am now. So when you talk about shorter implants, you have to talk about managing forces. You just have to. You know.
Makes sense.
I hope so. I'm out of here.
It makes sense to me. So that's
okay. If you and I agree, it's probably wrong. So.
What about resorbable versus non-resorbable? We've talked about, so the non-resorbable would traditionally be your space-maintaining, titanium reinforced. Usually if there's a vertical dimension, I think most people kind of go with the titanium reinforced. But I know you use a lot of resorbable membranes.
Yes.
How do you choose?
So say I take out I don't know, any tooth, just take out a tooth, and I don't care if there's a defect in the buccal wall of the tooth. If the adjacent part of the walls to the interproximal is still intact, that's a space-maintaining defect. So I'll use resorbable membranes anywhere that there's a space-maintaining defect. And it's very nice because a lot of times I'll go in, I'll take out a lower molar, I'll graft, I'll use a resorbable membrane to get a perfectly squared ridge. And I won't even make a flap when I go back to put the implant in if I didn't do it simultaneous because I know what I've got there. And of course, you can confirm it when you're giving anesthesia by needle probing. So yeah, I do use a fair amount of resorbable membranes because if you take teeth out properly, you shouldn't be, that's the wrong way to say it, I guess. If you take teeth out as atraumatically as possible, you should have good bone there. And I use a lot of piezo surgery to do that and other techniques. And you should be able to use a lot of resorbable membranes. Anywhere it's space maintaining, I use resorbable. Oh, excuse me. And space maintaining doesn't mean intact. It just means enough walls to hold the membrane and maintain the space.
Yeah. Yeah, that makes sense. Now there's a question here about fixation. Do you ever do periosteal sutures instead of tacks?
I don't. However, I know people who do. One of the gentlemen who works with me does, and I've seen some other people who you know as well who do, and it's working very well for them. I'm very comfortable with the tacks. The tack system I use, it takes me, well, when I do during a course, when you're on a video and you're leaning back and I'm trying to keep my hairy head out of the way, you know, it still only takes about 18 to 20 seconds to put a tack in. So it's very quick, and I'm just comfortable doing it. I've seen the periosteal suturing. I've done it. This is personal opinion. I believe I get more freedom with my mobility, etc., independent of the membrane position, my soft tissue mobility. The way I'm doing it, I just am comfortable with it.
Awesome. Hey, for our listeners out there, if you guys have any questions, if you go to the comment kind of bubble that has the question mark in it, you can send us your questions, and we'll try to get to many of those as possible. We got several in here still. What's your current go-to suture material for soft tissue grafting cases?
Well, let me back up there for a second. I'm sorry that I keep expanding the answer, but first of all, this is directly relates to I prepare the site. What I mean by prepare the site is the place everybody has problems is the lower anterior, right? They go do a soft tissue graft in the lower anterior. A couple weeks later, things pulled apart. If they use an allograft, it's a mess, and it's disgusting. So that's because that patient has a heavy mentalis muscle pull. So we use a lot of neurotoxin right here 2 to 3 weeks before we do the soft tissue grafting. It relaxes the muscle pull, and now the flaps stay together. In that case, I use mostly just chromic gut. Occasionally, I use some Vicryl. That's it. But if you've controlled the muscle pull, you can really use long verticals, reflect the tissue, and bring it up where you want to cover things. Again, neurotoxin first. Neurotoxin is vastly underused in what we do surgically and in our cases in general. People see it as something for aesthetics. It's something to help therapeutic success. So I use that first, and then it's either plain gut or some Vicryl.
Yeah, the neurotoxin, that's interesting. I hadn't heard that before. So you're doing that for, so that's Botox, right?
I use either Botox or Xeomin, same chemical with no preservatives. I use one or the other, yeah.
Okay, and you're saying for did I hear right? 2 to 3 weeks prior to? Is that like one treatment or multiple treatments, or
For the soft tissue grafting, it's so little. I may put 6 units, 3 and 3 right here. You wait 2 to 3 weeks for it really to take effect. You go and do your surgery. And I'm at the point now, you know, these patients have this very thin biotype. They get recession. They're like this as they're talking. Do you clench? No, I don't clench. No, I don't clench. Really, when do you get your drugs? You know, so that patient, I won't do that graft there unless they let me do that because it's going to fail. Yeah. So they don't have a choice. It's not percentage we can do. Is here's how we treat this. Bang, bang. That's the therapy. When I do a hybrid on a patient, full arch hybrid, they all get neurotoxins. They lost these teeth and they wore them down and broke them for a reason. You don't want to do it? I'm not doing the hybrid, you know, because I give patients a lifetime warranty with their implants. So, you know, it's no big deal. I'm Sicilian. I have them killed.
Here's another question. So you're talking about stocking the titanium reinforced membranes. Yeah. Like, do you have like some go-to sizes and shapes that you think cover most defect types?
I do, but this is embarrassing, Shane, because you know I never remember the numbers. Okay, so you got the single tooth one that sort of goes like this. You know, you want to know the truth? I'll bet you know the numbers. I ought it better than I do because I don't know the numbers. I keep a lot of the single tooth one. I keep a lot of the 250. Is that right? Something like that.
The 50 thickness. Yeah, I think I want to say that like what we call the posterior large is 25 by 30 millimeters. I want to say that you've that one, and then also the buckle, the one that kind of has the you know, the fat on the you know, if there's a missing buckle wall, and then has just kind of like the little tip over the top.
Exactly. But the biggest thing also is how many. I would never. I know I do a lot of volume of stuff, but I would never be without at least a dozen of all the size I like to have, because you never know what's going to happen, right? And things seem to run together. You'll get a day where you'll do 4 or 5 of the cases in a day. I'm going to sneeze from. Excuse me for 1 second. That's embarrassing. Give me 1 second.
Hey, while he's sneezing, hey, for any Osteogenics staff that might be on this live call, I'm seeing some questions come through the comments. If you guys would copy and paste those into the questions, because that's the feed that I'm checking. Appreciate it. Okay, go ahead, Paul.
And excuse me for a second. You have a nose my size. You have to sneeze when you have to sneeze, man. So anyhow,
I don't know anything about big noses, Paul.
No, I can tell. What a guy. So yeah, you just have to stock enough. And maybe this sounds foolish, but you can do a number of cases in a row. And I'm not going to say to a patient, I don't have what you need. So we've always got dozens of membranes there. We just do. You have to, you know.
Gotcha.
So.
Periimplantitis.
Oh, I froze. Or somebody froze.
Okay.
I'm against it.
Okay. Periimplantitis. So, you know, that's something that I think personally I've seen more and more lectures on. I've become more knowledgeable about. I think it's a super interesting topic. Yeah. In a lecture the other day, I heard that 10 to 20% of all implants will have periimplantitis in their life. I mean, that's a lot. I'm sure it may depend on, you know, there may be a lot of factors that go into that. Maybe that's a global number. Maybe you disagree. But
I do.
What are you doing? What are you doing to treat periimplantitis? How do you decide to remove versus treat? Maybe you could give us a little spill on how what you're doing with that.
Sure. Well, number one, I'm against periimplantitis. I want to go on the record just like that. Okay, just so you know.
Fair.
And honestly, not to be facetious, the best way to treat it is to prevent it. And let's start with that. I think you prevent it with comprehensive treatment planning, have comprehensive care, which the patient goes through if they want a lifetime warranty, getting thick enough bone, getting good soft tissues, etc. But that being said, look, I'm very self-critical of the stuff I do, and I have been for a very long time. So I'm just going to give you personal statistics, not because it's anything fancy, but that 10 to 20 to me seems very high. In all honesty, and please don't take this wrong, I think we're looking at 2%, honestly, 3% maybe, I think, over time if you're really managing the primary cause of implant loss and those statistics and that data, I'm sorry, as you know, I'm from Boston, so we have data, not data, you know, but the statistics in that data, the losses were not from periimplantitis. They were mostly disintegration and force. When we do have it, you ask the key question. How do you decide when to take it out and when to treat it? And I hate to say this, and I mean me too, we're all the same in what I say now. The primary motivating factor to take it out or keep it is whether you're the one to put it in. And I hate to say it that way. If you put the implant in, you do everything you can to save it so you don't look bad. If you didn't put it in, you take it out a lot faster, which makes no sense. But let's be honest, we all do that. That being said, what I look at for the patient is A, the stage of their life. My dad had an implant that was getting a little bone loss. He was 84 years old. I left it alone. He had a long implant. Back then, I used to do long ones, and it stayed for the rest of his life. Age, patient health. More importantly, the biggest thing is if I try to treat it and fail, how much worse off is the patient? That's where I start. You know, I've seen some things done that look great until you look at the reality of it. One time I lectured on a perio panel, and there was a gentleman, doesn't matter what country he was from, had this gigantic defect in this soft tissue grafting. It was the most amazing case I've ever seen, but he did 18 soft tissue grafts. I mean, how do you put a patient through that? What did it cost? And do you close your office for a month to treat this patient? The same thing. How much are you going to put the patient through when you can easily and minimally traumatically take out an implant with these tools nowadays and put a new one in and graft it? So unless it's a key thing on a prosthesis or a patient at a certain age who doesn't want to go through it, I'm much less forgiving of implants with problems. And I'm more apt to take them out because you can take them out so minimally traumatically now and repair the area. So will I keep them? It depends on what the patient has to go through and not if I can make it work. What happens if it doesn't work? Am I going to leave them with a worse defect? Excuse me, are they going to be worse off than they were? Am I going to hurt an adjacent tooth, etc.? So I really look at it that way. And the best way to treat a failing implant is to help it fail and get it the hell out of there, in all honesty. I look at some things that are done and I say, is this going to be okay in 5 years? Why did I put this patient through this and charge them a fortune for it? I don't keep crazy implants.
The prosthesis, you know, if you know, are you going to lose an expensive prosthesis, have to redo that? I've heard that is, and maybe it's more complicated than I'm, you know, simply stating it. But like how
no,
often,
that's a fair thing.
How often is the prosthesis, you know, basically complicated enough or expensive enough or customized enough, et cetera, to, you know, to justify trying to keep the implant? I'm just curious.
Yeah, I see what you're saying. Sure. No, absolutely. I mean, and you know, we've also got implants that have been for a long time that were put in with a different body of knowledge we had as well that may have problems now. I've got a patient who's got a full arch prosthesis on, I think it's 8 implants, was an old fixed case we did, and we didn't really understand the biotypes as well as we do now, et cetera, because it was done, honestly, in 1989. You know, it's still in her mouth, and we've done some surgeries to repair things, and she's got recession. It doesn't show. She's happy with it, and I've done heroics to try and hold on to this, and we've been able to. I think that's a case where I would do that for somebody. But now you come in, and you've got an implant in number 7, and you've got some buccal recession on it, and you've got a sign you get a little bone loss around the corners of it. Am I doing you a real service to fool around with this? And if it gets worse, not only that, the tissue gets more scarred down the more surgery you do, and there's less potential for the regeneration you want to do. I think that implant comes out. And the one that really bothers me is people take an x-ray at the time to check osseointegration or whatever, and they're getting ready to put the crown on it, and it's already got 1 millimeter of bone loss, 1.5 millimeters of bone loss. You haven't even loaded it yet. 2 millimeters of bone loss. This is when you take the implant out. Not, oh, it might be okay. No, it's not going to be okay. If you have to say it might be okay, it's not okay by definition. So I think there are times I've had, and the other one, I hate to say this, we've all put implants in, let's call it a non-ideal position, right? It's the same concept. What do you do? I've seen cases I've done, hopefully not too often. I say, geez, what the hell what was I thinking? And I'll look at the patient, I'll say, you know what? We have to take this implant out. And she'll say, why? And I'll be honest, I'll say, I have to take this out because I wouldn't leave it in my mouth. And I say, just like this. And, you know, I just realized I went into patient tone here, but that's okay. Because, well, that's what you do, right? Because I wouldn't keep this in my mouth. You came to me to have the best thing you can have, not to have something that's okay. I can't in good conscience leave it. I'm not going to charge you for it. I'm sorry. I have to take it out. And you take it out and you fix it. And I think it's the right thing to do. And we've all got them. You know, in the old days, oh, you know, if this implant, if you can't restore it, put it to sleep. Implants don't go to sleep. People don't pay my uncle go to sleep, right? So just take the thing out and put it in the right position. And it's the same thing with failing implants. If I screw up that number 7 you have and bind that tissue down with some recession, I'm not going to get you a good aesthetic result ever. Get it out and fix it, you know? That's my attitude. I think people try and save things. I see all, I'm not going to mention names, and actually I'm trying not to mention certain techniques because they're linked to certain people, but I've seen stuff done that was done in the late 80s we stopped doing because it was foolish. You got to understand too, when you prep an implant, you've weakened the implant. When you go in a broken screw and rethread the inside of an implant, it's now a thinner implant. I did a lot of IMZ way back. They were meant to have an intramobile element. People started putting titanium and they broke. You know, I don't think we have to compromise like that anymore. Get it out and put a new one in. Just take it out.
And we're getting, it's almost been 30 minutes. I want to ask one more question that it was asked a little bit ago. Healing times. So how long are you waiting? So I know you do a lot of immediates, and maybe you could just talk briefly, two questions. One is, when do you do immediate versus delayed? And then how long are you waiting to go back in and place your implant? And if you're doing immediate, how long are you waiting to load it?
Okay, so I'll give you a summary because you just said we're almost out. Then if you want to do this again, I'll go into much more detail, obviously. Yeah. So let's go over that, okay. When I put an immediate or not, that's a big discussion with defect morphology, et cetera. But if I do an immediate, depending on the defect and well, actually, let me back up, because what we're doing now a lot, I'll take out number 8, we'll do a scan, then I'll take out number 8. Then we'll put the implant in. Then we'll put a scan, but we'll do a digital scan. We send it to the laboratory. Within 15 minutes, they design. They send it back. And on our 3D printer, we print a provisional crown and we screw it in for the patient and they go home. So they're getting a lot of immediate provisionals that are not in function. They look like beautiful crowns that are printed right here in the office that day. Yeah. And we do a lot of that in the anterior now. It also holds the soft tissue beautifully. It's pretty slick. If I don't do that, if I put something in the socket, when would I not immediately load? A heavily parafunctional patient, a patient with a deep overbite, a patient with a super thin biotype, or honestly, a patient that I'm working with a restorative dentist is not comfortable making immediate provisional before we were doing this digital stuff, because you don't set things up for failure. Other than that, we would immediately provisional, not load, provisionalize, immediately provisionalize. If I don't immediately provisionalize, let's go over some timing. I can do this very quick. If I intact ridge, lower anterior, I'll go to final abutments and loading it 3 to 4 weeks. Lower posterior, depending on tissue quality, 4 to 6 weeks. Upper anterior, 6 weeks. Upper posterior, 8 to 10 weeks, depending on quality. If I've done concomitant grafting in a big defect, I may have to wait 3-4 months total. So I'll say 3 to 5 months, depending on the size of the defect. If I've had to rebuild a huge area, I took out a molar, I was able to get the implant in, I've got a big defect to grow the bone in, 4 to 5 months. But otherwise, I load pretty early. And now we're provisionalizing in the office before they leave a lot of times, which is great, you know.
Gotcha. So even in the biggest defects, whether you're doing immediate implant and it's out of function, or you're doing, maybe in the biggest defects, you're actually doing delayed, you're going back in basically in like 5 months or less.
At the most.
Okay.
Yeah.
Awesome.
You know, I'm getting older. I can't wait for this stuff, man. Come on.
Hey, well, this has been fun. This time flew by. I've enjoyed doing this. I think this would be a fun thing to do again.
Yeah, sure.
I know we got some questions we didn't get to, but want to try to keep this to about 30 minutes. But hey, appreciate your time, and let's do it again sometime.
2 quick things. First, thanks, man. It's fun. I always love talking to you. For those of you who don't know, we're fishing buddies too, and we've fished on a boat. I want to tell you, when Shane and I have fished on a boat, he's the second best fisherman on that boat, man.
Every time.
I'll talk to you later, man.
Hey, thanks, Paul.
Thanks, Shane. Bye-bye.